delay, let me introduce to you all our next speaker of this for the session, Dr. Rajesh Kumar Singh. Sir is Assistant Professor in Department of Neurology at AIIMS, New Delhi. Sir has published about 25 articles in index journals and 2 book chapters. He is also an assistant editor with Neurology of India. His keen areas of interest being neuroimmunology, neuroinfection, and stroke. So, Sir will be giving his expert opinion on yet another puzzling neuroinfection, that is neurocysticercosis, and the challenges that we face in its management. Handing over to you, sir. Sir, you can start sharing your screen.
Okay. My slides are my slides visible?
Yes, sir. Yes, sir.
Yes.
Yes, sir.
So after a quite informative lecture on tubercular meningitis by Modi sir and Dipti ma'am, we can move to another very common problem, which is neurocysticercosis, which is quite endemic in our country. So my talk will be under the heading of clinical presentation, diagnosis, management, and the IDSA guidelines. So we know that neurocysticercosis is quite prevalent in India, and it is a very endemic. And the clinical presentation, the neurocysticercosis can present with a variety of manifestations. The common include seizure, headache, focal deficit, IIH, even meningitis. Even we have one patient who have presented with multiple lesions in the basal ganglia and presented with Parkinsonism-like feature, so gait abnormalities, encephalopathy, and cranial nerve palsies. Basically, we divide neurocysticercosis in 2 headings, whether it is parenchymal and extraparenchymal. And under the extraparenchymal, it can be under the ventricular, subarachnoid, and spinal NCC. So we divide the parenchymal NCC have 4 stages, and that is vesicular stage, colloid vesicular stage, nodular granular stage, and calcified granular stage. This is the Scober's pathological stages. It is difficult to remember, but we have to know about the vesicular stage, as the NCC is cystic. So on we can just remember that on T1 it is just isointense to CSF, and as it is the cyst is not degenerating, so there will be no enhancement. There will be also no edema on the FLAIR image, and it will be it will be hyper intense on T2, and it will be suppressed completely on the FLAIR image. The scolex is best visible on the FLAIR image as a hyper intense and the eccentric part. Then then comes the colloid vesicular stage, when the cyst starts degenerating, and in this stage you can find the edema, mild to moderate marked edema will be there, most visible in the FLAIR and T2 images, and also the contrast enhancement will be there, and cyst will become thicker. The fluid will be slightly hyper intense to CSF in the T1 as well as in the T2. Then comes the granular nodular stage and nodular calcified stage, and in this the gradually there will be enhancement will be nodular, and but the edema will decrease, and finally the nodular calcified stage will come. So this is T2 MRI, this is T1, and this is FLAIR image. You can see on this there is hyper intense on T2. We can see here the scolex. On the FLAIR, it is suppressible, and the scolex is best visible, and T1 contrast, the cyst is isointense to CSF. And we can see there is no edema, there is no contrast enhancement on the T1 contrast. So this is the vesicular stage. So as the cyst starts degenerating, we can see the edema, the enhancement, and this is the colloid vesicular stage. So coming to extraparenchymal NCC, extraparenchymal NCC is less common, less well studied, more difficult to treat, and generally has a worse prognosis than parenchymal NCC. In extraparenchymal intraventricular NCC, the 4th ventricle is the site is more common as compared to 3rd ventricle as compared to lateral ventricle. And in the subarachnoid NCC, it is located on the cortical sulci, maybe basal systems, and as it can involve the leptomeningeal, it can cause even infarct, vasculitis, and hydrocephalus. So this is the extraparenchymal NCC. You can see here both the parenchymal, and as in the ventricles, you can see the intraventricular NCC. Here, these are the NCCs in the subarachnoid spaces, sylvian fissure, and in the basal part of the brain, basal systems. So the diagnosis is by the typical clinical presentation, which we have all know, and the neuroimaging findings. Regarding the CT is the best for seeing the calcification, and even the contrast CT we can pick the parenchymal lesion with edema, but the MRI is will better visualize the scolex and look for the we can edema part, and MRI particularly the ventricular NCC we have to if we suspect that any hydrocephalus and any calcified lesion is in the brain and in the CT, and we are suspecting that it can be intraventricular NCC. For this, we have to order the FISTA sequence and 3D sequence, in which the NCC ventricular part of the NCC becomes better visualized. We all know about the diagnostic criteria for NCC. It is for resident. It has been revised by the Del Bruto et al. In 2017. More or less, we all know the absolute criteria, the major criteria, the minor criteria, and the epidemiological criteria. But in this, they have revised they have added in the neuroimaging, they have subdivided in the neuroimaging criteria for the confirmation criteria. This is for resident, they must know this, and accordingly, a definitive diagnosis and probable diagnosis of NCC is made. Regarding, I will like to add about the serology. Usually, it is not required, but for example, in a spinal cord lesion or any NCC when we are not very confirmed, it can help. And ELTB, enzyme-linked immunoblot using parasite glycoprotein antigen is the best test which can be done. And ELISA using unfractionated antigen should be avoided. Regarding ELTB, just I want to add one slide. ELTB should be tested more, serum is more sensitive than CSF. And it can have, it is very much sensitive for multiple NCC, ventricular lesions or subarachnoid lesions. But it can be falsely elevated, falsely positive in those areas in which there are in endemic areas. And also, if there is previous infection and extraneural cysticercosis, then it can be false positive. It can false negative also in the case of calcified lesion only or single lesion. So it can add when we have some confusion or doubt about the NCC. CSF, regarding CSF, we usually think that CSF may be usually normal, but it is not the case. We have one patient who presented with asymmetrical hydrocephalus, in which on detailed evaluation on CSF examination, it was showing pleocytosis with meningitis picture. So even we are thinking of TBM, but when we look carefully about the hydrocephalus part, we order for the FISTA sequence, it was showing intraventricular cyst. So the NCC can present with the pictures of meningitis picture, particularly when the fever is doubtful, and particularly the ventricular, when it causes anaconditis or ventriculitis, the pleocytosis can be there with even elevated protein and decreased glucose concentration. So we should always be knowing about the mild CSF pleocytosis can be seen in the case of even NCC, parenchymal NCC. So coming to the treatment of NCC, before important consideration, we should, before starting antiparasitic drugs, ocular NCC should be ruled out, because it can cause edema, and even visual impairment can be a complication. Secondary, we all know about albendazole is poorly absorbed, and so it should always be given with meal. And hepatotoxicity and leukopenia are an important side effect. When we use prolonged albendazole, then we have to take into consideration this. The initial management is the management of seizure if presented with seizures, and if a patient presents with elevated intracranial pressure, then we have to manage accordingly. Maybe we have to use dexamethasone for that. Now, the questions to answer regarding treatment. whether what is the role of antiparasitic therapy in neurocysticercosis, whether albendazole should be used or whether praziquantel should be used, what is the role of antiparasitic treatment in the disseminated neurocysticercosis. So, usually antiparasitic therapy is warranted for patients with viable and degenerating or degenerating cyst on neuroimaging. It should not be used for calcified lesions. Antiparasitic therapy should not be used in the following three conditions: when there is untreated hydrocephalus, or there is high cyst burden, example for presenting with cysticercal encephalitis, raised ICP, and presence of calcified lesion. So, regarding the use of antiparasitic therapy. So, a systematic review and meta-analysis was done on the treatment of albendazole for the NCC. And this is the forest plot, and we can see the comparison was albendazole versus placebo or no drug, and the outcome was the persistence of lesions at the final follow-up, that is up to 1 year. So we can see for it is for viable lesions and it is for non-viable lesions. We can see for viable lesions, the diamond is favoring albendazole. It is not crossing the line of no effect, and we can see the risk ratio 0.56, and it is not crossing 1, so it is statistically significant. So for viable lesions, the albendazole has definite a role in resolution or early resolution of the cystic lesion. However, for the non-viable lesions, you can easily see the diamond is crossing the line of no effect. So we conclude here by this meta-analysis that in patients with viable lesions, evidence of the trials in adults suggests albendazole reduces the number of lesions. This was further strengthened by another good trial on albendazole treatment on NCC, which is published in JNNP in 2008 by Carpio et al. And in which they have given albendazole in almost 60 patients, and placebo in almost 60 patients, and they found that albendazole plus symptomatic treatment led to disappearance of active cyst in 31% of the patient, compared to 7% of those who received symptomatic treatment alone. So this treatment effect occur within 1 month period. So with this, there was no doubt that yes, albendazole is should be given for the patient with who are having viable cysts. And whether we should give albendazole or praziquantel, the albendazole has different mechanisms of action as compared to praziquantel. Albendazole acts by the energy depletion, while praziquantel causes muscle paralysis. So there have been again a meta-analysis done whether we should use albendazole versus praziquantel. There are 2 RCTs and 4 prospective cohorts, and the outcome was reduction of the seizure frequency and disappearance of the lesion. So again, for the albendazole versus praziquantel, the outcome was total disappearance of cysts, and it favors the albendazole. We can see the confidence interval again, and odds ratio, it is 2, and the confidence interval is again not crossing 1, so it is statistically significant. So for disappearance of cysts, albendazole is found to be more effective than praziquantel. Also, for the control of seizures, it also favors the albendazole as compared to praziquantel. So, one study, this is a landmark study, it was done by Gracia et al., and in which they have used dual therapy. So, whether combined antiparasitic treatment for neurocysticercosis, they have the PICO was patient with multiple NCC, and they have given combination albendazole plus praziquantel in the dose of 15 milligram and 50 milligram. And control was either standard albendazole dose or increased dose of albendazole, and the outcome was complete cyst resolution on 6-month MRI. And what they found that they have used multiple NCC. So for 1 or 2 cysts, the albendazole plus praziquantel group and the albendazole group, there was no difference. It was statistically almost same, and not statistically different. But for 3 or more cysts, the complete resolution of cyst was found in 68% of the patient with dual therapy, while for a standard albendazole it was 5%, and for increased albendazole it was 25%. So based on this trial formed the basis for the IDSA guidelines, in which they say that for 3 or more cysts, we should use dual therapy rather than single therapy. And for 1 to 2 cyst, we should use a single antiplatelet therapy, a single antihelminthic treatment, albendazole can be used. But in this trial, they have not incorporated more than 20 cysts. So they have excluded patients who are having more than 20 cysts. So combination of albendazole and praziquantel increases the parasitidal effect in patients with multiple brain NCC without increasing the side effect. So the IDSA guidelines for 1 to 2 viable NCC, we can give albendazole for depending on 10 to 14 days. For more than 2 NCC, the combination therapy should be preferred and should be given for 10 to 14 days rather than single drug. So for antiparasitic drug in patient with solitary enhancing lesion, albendazole therapy should be preferred and it should be given for 1 to 2 weeks. Now coming to another disseminated NCC. Disseminated NCC is defined as those who having multiple lesions in the brain, at least 3 or more, and with involvement of one extra neurosite like subcutaneous tissue, skeletal muscle, eyes, and presence in any visceral organ like liver, lung, spleen, and heart. And cysticercal encephalitis, we should know about when there are starry sky appearance or multiple NCC and patient presenting with encephalopathy, raised ICP, papilledema, they should not receive antiparasitic treatment. This was only for disseminated NCC. So this is, although this is not a RCT, this is a prospective study, and this was Abdul et al., Professor Garg, they have conducted, and they have given this in disseminated cysticercosis 20 patients, they have given albendazole, and what they have found that albendazole resulted in complete disappearance of all cerebral lesions in 35% of the patient, and reduction in lesion load in approximately 65%. And there was no significant change in the lesion in those patients who did not receive albendazole. So based on this, they have one more paper on prospective, although in which they have given 3 cycles of albendazole for the disseminated cysticercosis. So this was the paper where they have given an example. They have multiple NCC in the brain. It must be more than 20 and almost complete resolution after giving a prolonged albendazole therapy. This was the case series even recently published by one of our colleagues, Ayush Agrawal, and they have 3 patients of NCC in which they are almost more than 20 lesions in the brain, and they have given dual therapy. Because dual therapy at present, as per IDSA guidelines and as per the recent, as per the trial, it was restricted to 20 only. But in this, they have in 3 patients they have given dual therapy, and you can see the lesions. This is the T1, this is the T2, and the flare, T1 contrast, and SWI, and almost there was complete resolution. Even in some calcified lesions also, which was showing blooming, the lesions, many lesions get improved. So although it is a controversial topic, there have been reports of death even in the patient who have given antiparasitic treatment. But yes, a randomized control trial is warranted before concluding that it can be given in starry sky or multiple NCC, and definitely not having raised ICP. But these patient group comprises quite in which they become steroid dependent, and ultimately they enter a vicious cycle in which there is seizure. Again, we have to give a steroid. They become steroid dependent. So a randomized trial can answer about this group of patients. So the role of anti-epileptic drugs in NCC. It was for the solitary granuloma, and again a meta-analysis has been done, and it was done for about 6 months. Duration of it was 6 months versus 12 to 24 months, and the outcome was seizure recurrence. As we see, there is no statistically significant difference. So again, 6 to 12 months versus 24 months, again there is no statistically significant difference. So 4 studies address the duration of anti-epileptic drugs for the seizure control in people with single cerebral cysts, and there is no clear benefit of either short duration or longer duration of anti-epileptic drug, and no superiority of one anti-epileptic drug over another. Although when we use praziquantel, then sometimes it we use phenytoin and carbamazepine, they can lower the level of phenytoin and carbamazepine level. So we should know, although albendazole does not cause much interaction, but praziquantel can lower these two anti-epileptic drugs. So anti-epileptic drugs in all NCC patients should be given with seizures. And in those patients in multiple NCC, if there is resolution of the cystic lesion and there is no seizure for 24 months, then we can consider tapering off. The choice of anti-epileptic depends on the cost, local availability, and drug interaction. But for solitary enhancing lesion, if the lesion have disappeared on the MRI and the patient has been symptom for 6 months, so we can consider the tapering of anti-epileptic drugs in these patients. This is the IDSA guidelines. We have talked about the parenchymal part, but the extra parenchymal recommendation for therapy of extra parenchymal NCC. The intraventricular, that is for the lateral and third ventricle, the minimally neuroendoscopy approach will be the better approach. For the fourth ventricle, either we can go for microsurgery or endoscopic. When the intraventricular cyst, when it is not removable, when it is adhered, then we can do for deficient, and then we can give antiparasitic and anti-inflammatory therapy. The subarachnoid ones are more difficult to treat, and they usually require prolonged therapy. So if it's presenting with hydrocephalus, we should give surgical management first, and we should not give antiparasitic treatment in the presence of hydrocephalus. It should be treated first, then we can give antiparasitic treatment, and they often require prolonged administration of albendazole or combination therapy with albendazole. And we have to, when we use for prolonged therapy, we must know the side effect of these drugs, particularly albendazole. For recommendation, we have already learned for viable parenchymal lesions, for 1 to 2 monotherapy. For more than 2, we can give albendazole plus praziquantel. And for anti-inflammatory therapy, corticosteroids should be used when the antiparasitic drugs are used. Anti-epileptic drugs will be used in all patients with seizures. And already told, if there are multiple NCC and if they have MRI, so the resolution of the lesion, we can consider tapering off after 2 years. For single enhancing lesion, again, albendazole alone is enough. Anti-inflammatory therapy should be given, and anti-epileptic drugs will be used, and that can be tapered off after resolution. And for calcified therapy, we should not give any antiparasitic treatment. When we have present with cysticercal encephalitis with diffuse cerebral edema, we should not use antiparasitic treatment, and we should treat cerebral edema with the corticosteroids. So the take-home message: antiparasitic treatment is important, but never an emergency. And for parenchymal, cystic NCC has better outcomes if it treated with antiparasitic drug along with corticosteroids. For subarachnoid, chronic therapy is required, intensive antiparasitic therapy is required, and surgical therapy. For ventricular, the third and lateral ventricle, minimally invasive surgery, and for fourth ventricular, maybe open craniotomy or invasive surgery if required. For calcified, no treatment with antiparasitic drugs, but antiepileptics will be used when they present with epilepsy. And even if calcified lesion present with drug refractory epilepsy, then they can be considered for the surgical management. Thank you.
Thank you very much, sir.